Hello, everyone, and welcome to our August PQA Quality Forum Webinar. My name is Amanda Ryan. I'm the Director of Education here at PQA, and today's topic is the essential role of pharmacists in transitions of care. As we do with every quality forum, I would like to review a few housekeeping items before we get started. First, please submit your questions throughout the presentation using the Q&A feature that you will find at the bottom of your screen. We will collect your questions as the speakers are presenting and then have a panel discussion in the latter part of today's webinar. Also, the webinar recording and the slide deck will be available to PQA members within the week following today's webinar, and you'll be able to find that in the member resources section of the PQA website. Additionally, we will be posting the recording of today's webinar on PQA's YouTube channel. And lastly, I would like to encourage you to please take the quick 1-minute survey that will launch at the conclusion of today's webinar. We do always appreciate your feedback and utilize that in constructing future programming. I'm pleased to introduce you to today's speakers, who all have been expert advisors for the National Transitions of Care Coalition Pharmacist Task Force. First is Amina Abubakar, who is the owner and CEO of Avent Pharmacy and Wellness Center, and is also a member of the PQA Board of Directors. Also with us is Klodiana Myftari, who is an assistant professor of pharmacy practice at Midwestern University Chicago College of Pharmacy. And finally, we have Sara, the Manager of Pharmacy Ambulatory Care, Population Health, and Transitions of Care for Baptist Health South Florida in Miami, Florida. You can find full bios for all three of our speakers in the email announcements and the registration page for today's webinar. I would also like to offer special thanks to Norris Turner and Sherry Latimer from the National Transitions of Care Coalition for their support in coordinating today's webinar. Thank you to Amina, Klodiana, and Sara for being with us today. And with that, I will turn the floor over to Amina.
Thank you. So the session objectives for today is to define the issues related to transitions of care, review the role of the National Transition of Care Coalition Pharmacist Task Force, recognize the pharmacist's role in care transitions bundle, and discuss the 10 principles of transitions of care pharmacist. So in the United States, higher risk of admissions are due to drug-related problems, and these problems were driven by polypharmacy and advanced age. So if you look at this, that these admissions have costed Medicare annually around $15 billion. And when looked further, out of the $15 billion spending, $12 billion had preventable solutions. So as we look at the whole problem with transitions of care, it's really important to look at the ineffective transitions of care as a huge expense for our healthcare industry. And I would say, especially if the patients are admitted within the 30 days of post-discharge window. Pharmacists play an active role in improving medication safety during transitions, and these have shown to lead to reduction in hospital readmissions and improved quality. However, the gaps that are existing currently, and what we would call the transitions of care issues, is one, there's poor communication between acute care, post-care, ambulatory, and community resources. And also, as much as we do see pharmacists participating in interdisciplinary care teams for transitions of care, but they're not many. And those who do have a role in transitions of care, we also see a minimal standardization and consensus of the transitional pharmacist process. Other challenges is the financial reimbursement, because to have this team member, most folks ask, how do we pay them? Siloed technology is another barrier and a challenge, and the whole EMR integration with pharmacists and between levels of care as these patients transition.
So where are we now? So thank you everyone for being here, first of all. And what I wanted to talk about is how we have then reached out to NTOCC and how NTOCC has supported the pharmacist role in the creation of the task force. So why am I here talking to you about this today? One of the things that I recognize and what was kind of the straw that broke the camel's back for me was I was on a meeting one time and talking about my role as a pharmacist in transitions of care. And after the meeting, the nurse came up to me and was like in awe of what pharmacists could do and really said, I didn't even know pharmacists could do any of this stuff. I would love to introduce you to Sherry Latimer from NTOCC and have you discuss more. And so I said, absolutely. So after discussion with Sherry and convincing her, there was a call to action to healthcare industry that brought 16 of us together to discuss the issues facing pharmacists providing transitions of care services. Through the NTOCC board, they created some goals, and the first was to discuss and gain alignment on the role and function of the transitions of care pharmacists, develop a consensus statement, define current issues and aligning financial incentives and accountability, assess the need for an infographic, which then can be used to educate not only the patients, but providers, payers, and caregivers, as well as to use it for legislative and regulatory agencies, and to evaluate educational needs for TOC pharmacists responsible for transitions of care programming. So here are the 16 participants for the NTOCC pharmacy task force. And what I want to note here is the variety of participants in here. So as you can see, mostly pharmacists, but one of the things that I want to point out is we are all from varying practice sites. You have the healthcare system representation, you have community representation, you have academic representation. Outside of pharmacy, we had a physician, we had nurses, we had case managers. So it was a very wide variety of like-minded folks, but in various areas. And at this point, I want to now turn it back over to Klodiana to continue with the 7 essential interventions.
Thank you, Sara. I'm going to start by highlighting really the role that NTOCC has played and the time it's been invested in resources in really creating a bundle to highlight the 7 essential interventions that can make a transitions of care successful. There are several publications that speak to what those essential interventions are. And we want to make a point that this bundle, it is not necessarily a model of care, but it is designed to be considered in improving transitions of care for the population and patients that we serve. It was around the same time when the NTOCC put together an interdisciplinary task force to update the NTOC Care Transition Bundle that the NTOC also called the Transitions of Care Pharmacist Task Force. And together we worked to enhance one of the elements of the bundle, which is the medication management services and coordination category. We all agreed that highlighting the role of the pharmacist, it was very important. And we, based on the current data and the literature, we know that the pharmacy scope of practice elevates and improves transitions of care. We apologize that this slide is a little busy, but there are a few points that we want to point out here. Usually when we talk about transitions of care, the first thing that comes to mind is the patient's transition from an inpatient setting to home, or from an inpatient setting to a skilled nursing facility, or from home to hospital setting. And I understand why, because usually that is a very critical time in the patient's care. However, when we think about continuum of care, transitions of care, it's happening every time the patient's is transitioning from one care team to the other, or from a care team to their own self-management. And this is the first point that we want to highlight in this slide. You can see that every point that it's listed here in the continuum, it is considered a transitions of care. The second point that we want to make in this slide is that while we have highlighted the 7 essential interventions, and not in any particular order, You can see that pharmacist's role is highlighted primarily when we talk about medication management services and coordination. And also when we talk about healthcare providers' engagement and shared accountability to ensure that patients has the best access to the continuum of care. However, it is important to recognize that pharmacists actually play a significant role in all other elements, and they intervene and they can provide expertise anywhere from the follow-up care or the education that could happen regarding medication use, regarding different equipment, a role in educating or assessing patients' social determinants of health. So again, while we're going to continue to speak and focus specifically more on the medication management service and coordination, pharmacists can be a great partner in any one of the 7 essential elements. So let's break down medication management services and coordination. Again, this is another busy slide, and it's not our intention that you're going to review this right now, but we hope that you will refer back to these slides as you are going to review your current transitions of care services and what are the pharmacists doing, or what are some of the services that the pharmacists are providing in your transitions of care services. What we focused on is ensuring the safe use of medications by patients and their identified family caregivers, with focus on the patient's plan of care. And we believe that the pharmacist should be involved and be an essential part in number 1, assessing patients' medication lists and need. Number 2, assess social determinants of health factors that will impact the safely use of the medications, anywhere from simplifying the medication regimen or the medication schedule, to assessing health literacy, to educating patients on how to properly use medications. And then lastly, to develop implement a plan for medication management services as part of the patient's overall plan of care. And all of this, it is what was discussed in detail in our meeting as the pharmacy task force. Next slide, please. And that's where the National Transitions of Care convened the task force, and they've been committed to provide education, resources, tool, and develop public and professional awareness, partnering with mind-like organizations in order to acknowledge and, most importantly, to advocate for the essential role that pharmacists plays in the transitions of care. And at this point, I would pass it to Sara to review the 10 principles that we believe will drive and help create a transitions of care services that will be easy, evaluated, and assessed in the future and ensure a better transitions of care for our patients.
Thank you so much, Klodiana. So prior to me getting into the 10 principles, I did want to share one aspect that when I had my conversation with Sherry, and this is really where a lot of this work has come from. You know, we do work with a lot of organizations, a lot of pharmacy organizations that have taken stances about pharmacists, but why NTOC and why pharmacy? One of the big reasons is when you talk to other disciplines, a lot of the times they feel that pharmacists, you know, the pharmacists are doing quote unquote transitions of care, and that is regarding medication reconciliation. But we as a team and in task force have said it's beyond medication reconciliation. There are so many other things that we can do, which was really the kind of base of the principles. So here I'm going to go into the principles and speak a little bit more about specific ones that we would find of interest to the PQA members. So we, the task force members, have committed to the following principles. Number 1, we advocate that pharmacists have a crucial role and impact in improving transitions of care for patients, their identified family caregivers, and providers within the healthcare continuum. Number 2, we advocate that pharmacists to be an integral member of the interdisciplinary team at each level of care, transitions, and coordination. And this one in particular really resonates, and why I want to talk about this and why I started with the MedicRec example is that when we talk to providers and we talk to people, when we try to identify where pharmacists lie within the continuum of care or the assistance in transitions of care, typically they're placed within the medication reconciliation process, and that's it. What we're advocating for is that they are truly a member from start to finish, from that intake, that medication reconciliation, through the decision making of what the patient should be on medication wise, taking into account their social determinants of health, as Klodiana has mentioned previously. Going into the discharge, are these medications feasible, things of that nature, which we will talk about in a later slide with a different principle, but that is why we advocate that the pharmacist is a part of that integral interdisciplinary team. Number 3, we acknowledge that while no one discipline is fully responsible for care transition or coordination, we advocate that a larger involvement by pharmacists beyond medication reconciliation will help realize an improved standard of care, including medication management services and overall quality of care, as well as patient satisfaction and safety. Number 4, we believe that pharmacists are an integral part of the quality healthcare delivery and thus play an essential role in helping to improve healthcare communication, a core element of quality transitions of care between patient, their identified caregivers, and providers. I want to take a pause here for 1 second, because I'm sure in this webinar right now, we do have a variety of clinicians and various practices as well. Think about the struggles that pharmacists have, and I have it on a day-to-day basis. When I work and I try to call out to my community pharmacists, they are getting bombarded. They are very busy trying to fill the prescriptions and work in their process as well. And you know, one of the things I always take note is that they work in a silo, unfortunately. A lot of the times, they don't know what is going on in terms of what happened in the hospital stay. And what we want to do is really try to bridge that gap between all providers and try to help with our community pharmacists, our pharmacists who are on long-term care, to be able to streamline that communication, and not just amongst pharmacists, but other providers as well, and also caregivers too. Number 5, and this is probably our longest principle with much more detail to it, but we advocate that pharmacists practice medication management services, inclusive of assessment of patients to determine their clinical status, and we prioritize patient problems, medication-related needs, including medication access and barriers, assessment of social determinants of health that could interfere with patient access to medications, and follow the medication plan. I am going to take a pause here for just 1 second, because I think this is truly the bread and butter of what transitions of care truly is. I want to speak on my role for just 1 second. I was brought into Baptist Health South Florida to try to standardize the practice of transitions of care. Now, even amongst my own healthcare institution, we had transitions of care at each of our individual entities or hospitals, and I noticed everybody was delivering transitions of care a little bit differently. You know, one person would do discharge medrec and education, one person would just do discharge medrec, one person was assessing barriers. And one of the things I asked was, how do you know, after all this work you've done, that the patient is able to get their medication and be adherent to it? And they said, we have no idea, we don't know, we just assume, you know. And I realized that the pharmacists were taking a much more, and I'm going to call it a backseat approach to transitions of care. That we were looking at the care plan set by the provider and nurses or any other provider in that patient's care and accepting it for what it is. What I tried to move with my pharmacist is to be much more active and involved in their medication needs and really assessing their, what I call chronic care management on an acute care stay. Looking at, is this something that not only do they need medically, but will they be able to take it? Is it a complex regimen that they might forget and not be adherent to? when sending their medications to a pharmacy, are they able to get to the pharmacy? Are they able to drive to the pharmacy to pick up their medication? Do they have to now prioritize the cost of medication over their medications, which is that social determinants of health part of it? So really, this is the stance that we like pharmacists to start taking when evaluating the patient's medications and transitions of care. We'll next move into the patient advocacy and support of their medication care plan to optimize their therapy and achieve patient and caregiver specific outcomes. I always have a specific story in mind with this one. I think as clinicians, we always think that the betterment of health is their motivator for their care plan. But I had a patient one time who, we explained to her that without these medications, her health would diminish, and she just was not motivated. I sat down with her and I talked to her and I said, okay, what is your motivation? And I had that motivational speech with her, for instance, and she told me, I really hate that I'm losing my hair. And it was due to her disease state process. So I actually kept in touch with her. I bought her some headscarves to cover up her hair that was, falling out. And in the meantime, I helped work with her and supported her through her medication plan and optimized that therapy. And she finally took it and was motivated to take that medication. And then I saw her 6 months later, and she was in a much better, she was much healthier. And actually I didn't recognize her because she looked healthier too. So it was a wonderful experience on my end. The next is to active engagement and education for patients, identify family caregivers, providers, and other members of the interdisciplinary team. I know for myself, going through pharmacy school and even post-pharmacy school, we always talk about utilizing open-ended questions and talking about talking to the patients and educating. And I think a lot of the times we force our education onto the patients because we feel like we need to. I think we need to be better at assessing what they know and filling in the gaps of what they don't know, and including the family members and other caregivers, even the providers, into this education for these patients. Next is coordinating and ensure the pertinent patient information is transferred between care settings. Very often we're seeing that there are changes made, again, we always think about hospital kind of being the starting point of transitions, but let's use that as the starting point. We always see medication changes happening on the hospital end. Patient is followed up with a primary care provider and something's lost in translation. What we're advocating for is that the pharmacist help that coordination and ensure that the medication transfer information on medication is provided to the various care settings, whether it be the primary care provider, the specialist, a skilled nursing facility, long-term care facility, wherever their post-acute care stay is. Next is ensuring medication continuity, immediate and sustained medication access, which includes insurance coverage, financial assistance, appropriate packaging, prior authorization, and compliance. Now, the way, again, I have a lot of sayings, but the way I look at this one in particular is that when we give coupon codes out, it's a Band-Aid over a bullet hole. We are hemorrhaging, and the patient is not able to afford these medications, but we give a coupon to give them 30-day supply. But we don't think about that next sustainable medication access question, which is what happens after the 30-day supply? What we would want to do as a group as pharmacists is to help ensure that continuity of care and then continuity of medication. For instance, in my clinical setting, we are providing prior authorization assistance and patient assistance programs as well. Next is follow-up care, including post-transition monitoring of patients and identified family caregivers, and a warrant handoff to the next level pharmacist between care settings. Ideally, we would love to be able to talk to our community pharmacists and be able to hand off any issues or remaining concerns to them. the other area of development for pharmacy is our ambulatory care setting, to be able to hand off to those pharmacists to be able to follow through on a more longitudinal aspect. And that's really where we can see the growth of pharmacists within the transitions of care setting. Next is accept accountability for the highest attainable quality of care in collaboration with the interdisciplinary care team to enhance clinical care and improve patient safety and satisfaction. Number 6, we support a financial reimbursement model for pharmacists which would recognize the unique and valuable role and expertise the pharmacist brings to each care transitions through their assessment, management, monitoring, and advocacy to improve patient quality, safety, and satisfaction. I think this is a pain point across all of pharmacy services. We would like to get reimbursed for a service we have notoriously been giving out for free for several years. Our clinical services and our what I call our intellectual property. We would like to finally be able to be recognized as healthcare providers and to be able to get reimbursed for our services. Right now, we in several states or in several areas, we have to be very unique with how we get reimbursed, whether it's incident to billing through our clinics, working with collaborative practice agreements, and trying to figure out how can we bill under other providers. I think that one of the things that we need to work on as a profession is really coming together and getting that financial reimbursement across nationally. I know there are some states who have done very good jobs of creating those financial reimbursement models for pharmacists, but we're not there yet. We're in the very baby stages of this. So we're really looking forward to continuing to push for these financial reimbursement models. Number 7, we believe that patient contact and interaction, whether face-to-face, telephonic, or through virtual visits, are essential components necessary for pharmacists to provide quality medication management services that enhance transition and care coordination. Number 8, we advocate for the concept that pharmacists in all practice settings, including acute care, post-acute, outpatient, community-based, palliative, and hospice care, are essential to the delivery of the quintuple aim: improving the patient's experience of care, improving provider experience, improving the health of populations, advancing health equity, and reducing the total cost of care. Number 9, we encourage interested pharmacists to consider specialization in transitions of care as an advanced practice initiative. And lastly, number 10, we conclude that pharmacists' demonstration of their clinical expertise, commitment to a code of ethics, and dedicated interactions professionally and collegially with others should earn them respect and acknowledge its crucial role on the interdisciplinary care team. So when we were working together as a team, we had, I believe it was 4 to 5 sessions as a task force. And when we were brainstorming and talking as a group, and one of the things after one of the meetings, I said, I really heard some trends in words, and I would love to go backwards and figure out how many times certain words were said. And so we created this word cloud and these common themes from our task force and our work together. What I do want to point out, and one of the things I kind of stopped on with our principals, is the one all the way to the left, which is reimbursement. I think that, or I truly believe that pharmacy services could be extremely enhanced within the transitions of care realm if there was some sort of reimbursement model that we can push for and get attached. Now, there are transitional care management codes that pharmacists can assist with primary care providers in doing, But then what is the structure and how can we do either a cost sharing or something along those lines? But again, we're tying ourselves in to a provider and in hopes that we get part of that reimbursement. The other one that pops out to me is communication. I think a very general trend with transitions of care and a very big challenge that we have is communication. We don't know who is the main driver, or I call the quarterback of communicating for patients. But I also think that over communicating can never be an issue. I think if we over communicate, we're at least able to kind of close off some of that Swiss cheese and prevent lack of communication for these patients. So I do, you know, whenever you get a chance to look at the words and things here, I really encourage that. And then one of the things that just popped out to me, even though small, is advocacy. I'm a very big advocate for the profession of pharmacy. And I think that we will go, no one else will advocate for us as pharmacists besides us. So any chance you have to advocate for your profession, whether it is through legislation or through your state's PACs or anything of that nature, I would highly encourage us as a pharmacy team, or even if you're not a pharmacist and you support the pharmacist role, to help support and advocate for our role in the healthcare setting and within transitions of care as well. So what are the next steps for NTOCC within the pharmacist role, especially after the pharmacy task force completed in 2021? So the board for NTOCC recognized all the hard work that the task force did and really felt that there was much more to be done. So NTOCC actually established a Transitions of Care Pharmacist Advisory Committee, which I am fortunate to chair this year. And I'm very excited and working with these two lovely ladies that I'm presenting with today. We want to create resources to build education and awareness for the importance of integrating the pharmacist within the disciplinary team. Again, going back to that initial issue of not pharmacists understanding what we need to do for transitions of care, but having the interdisciplinary team understand what the pharmacist can do. We want to outreach to additional like-minded organizations for their pledged support for the advancement of the pharmacist principles. For instance, here we're thinking of teaming up with our pharmacy, our big pharmacy groups, such as PQA, APHA, ASHP, so on and so forth. I think that we have and beyond to really tie in not only the pharmacy-based organizations, but I call it discipline agnostic organizations such as NTOCC. Support the build of educational materials and content for TOC pharmacists. As I mentioned before, a lot of the times we're doing a lot of things on the whim. We think that we're providing transitions of care and everyone thinks what they're doing is TOC, but I think that we want to build and educate our pharmacists to all of the things that they can do. We want to partner with the other organizations mentioned previously to support financial models of reimbursement for the expanded role of pharmacists. And lastly, develop resources for patients and their identified family caregivers about the support pharmacists can provide in transition and care coordination. So here we're showing you kind of the pamphlet of, or the nice version of our TOC principles that we would be handing out and showing to everybody. Over here is the link for it as well. Lastly is the infographic that we've created. So it's snippets of our principles that we have, and this will help with our legislative efforts, as well as educating our providers in what can be done for transitions of care with pharmacy services. And I know we went pretty fast, so with that, I will open it up to questions, and thank you very much for your attention.
All right, thank you so much, Sara, Amina, Klodiana. I appreciate you sharing all the work that you've done with us. And now we will transition to our question and answer session. So I'd like to remind attendees, if you do have a question for our speakers today, go ahead and put that in using the Q&A function that is at the bottom of your Zoom screen. We do have a few questions that have come in, but we will certainly have time for some more. So please go ahead and send those our way. The first one is really about communicating with patients and pharmacists post-discharge and the methods by which you might be able to do that. So beyond phone calls, are there other ways to communicate with patients and pharmacists after discharge? Anything that maybe you have tried that has worked well or something you might like to try? Amina, go ahead.
Sure. So by leveraging resources within the community, when you answer this question, you really have to think of the setup with who's transitioning the patient. So for example, I'm a community pharmacist and we have relationship with ambulatory care pharmacists. And when they send us information about the patient that we already know picks up prescriptions at our pharmacy, we can take that care plan they had for the patient and we can continue face-to-face coaching because we have more touch points with those patients. And also just leveraging other care team members like case managers. So it's not one person's responsibility. I think that's how I would address it. And different patients are responding to different methods, but also with the evolution of digital tools, there are many ways now you can send a survey to a patient and have them answer a few questions and respond, because even our baby boomers are very savvy at texting now.
And I want to add one thing to this, and I think, Amina, you did touch on it. So, in my setting, I work in a healthcare setting or healthcare system setting, excuse me, and we have established ambulatory care pharmacists as well. Now they're considered ambulatory care, but one of the things that we're building out too is a transitions of care clinic that I know a lot of healthcare systems have already established. Now, does it have to be through a healthcare system? Doesn't always, but they tend to support services like that from pharmacy a little bit better. So we're in hopes to create a transitions of care clinic where a patient can come to. Again, the struggle is billing for that service and supporting that service a little bit better. But I think that down the line, once we start growing our, and advancing in our career, or not career, in our profession, I think that we can do that a lot more.
One more comment that I would like to make. So my current practice, I practice at Rush University Medical Center, and our transitions of care model, it is primarily telephonic. But there are a few other ways that we've tried to be successful. Number one, it's important to recognize that not every patient who is going to be discharged from the hospital or any patient in transitions of care requires the same level of pharmacist involvement. So starting by making sure that our patients know who to reach out to or which pharmacist to reach out to in case they have questions about medication, it's the first step. So empowering patients to reach out when they need support is something that we found it to be very helpful. A second way of how we've engaged with patients, besides using technology and allowing, we have an automatic system that will reach out to patients. We will ask automatic questions. And then if any one of those questions is positive, then we'll connect the patient to a live person, to a pharmacist if needed. We're also utilizing video visits as a way to connect with our patients post-discharge. For many of the members in the team, you probably, and on this meeting, you probably know Doximity is one of those tools that it's been available to many pharmacists. That is something that we've utilized and utilized that video options there as well. And then really trying to meet patients at the primary care visit, at the transitions of care visit. That's another way that we've been able to incorporate pharmacy services as part of that transitions of care visit with primary care.
Right, very good. Thanks to all of you for commenting on that question. I really appreciate the fact that we have kind of both sides of the care transition spectrum here today. Those perspectives are really helpful. And for this next question, I would be very interested in hearing from, outpatient and inpatient experience related to maybe tips for pharmacists, especially those outpatient pharmacists that might struggle with how to best communicate to the pharmacist who took care of that patient in the hospital. So sometimes that can be a challenge to really know who to talk to and how to do that. Any tips from either side here on potentially how to help pharmacists in the outpatient setting with communication?
I'm happy to answer that. I feel like where we are today, having those conversations with those teams that are responsible for the transitions of care and allowing whether it's a read-only access or messaging access for the outpatient pharmacists to be able to communicate. We're already seeing that in some of the health systems around the countries with different pharmacists that I'm working with. So I feel like the dialogue is happening now, especially post-COVID. There was a lot of limitations on how patients could access different things. So I feel like it's the health information exchange and to get permission, even if it's read-only or messaging back and forth.
And I want to add to this kind of more from the healthcare system side of things. So it is challenging, and I acknowledge that it's very challenging. And one of the things that I've done with some of our local pharmacies is I've provided them my contact information, and I've said, if you need information from any of my hospitals, now mind you, I'm an 11 hospital system, please contact me and I will guide you to the right place. So we recognize that it's not just, it's bi-directional issues. It's us trying to contact the pharmacy from the healthcare side, but probably even harder is the pharmacy contacting the other way around. Now, in our role from Transitions of Care, that's why we try to also be proactive with identifying potential issues with those patients. And a lot of the times we've called the pharmacy and they're like, oh my goodness, yes, I've been having this issue. Thank you so much for calling. I didn't know who to call. So we're trying to be much more proactive until we can get those partnerships a little bit better. But I think it's a known issue across the board. And I think that there's lacking infrastructure there, which I think, again, if I could wave my magic wand, we would fix that right away. But yes, that would be my suggestion.
All right, so the next question we've had come from a couple of attendees asked in slightly different ways, but I feel like this is a perfect question for a PQA webinar. And that is, how do you measure the impact or the quality of the services you provide? Either how do you do that now for transitions of care service, or how might you do that if you're not to that point yet? Is it looking at readmission reduction? Is it adverse drug events? Any other ways to measure the impact and quality of services?
Yeah, I can start to address this, and I'm sure that Sara and Amina will have other opinions as well to add. The first thing that I want to point out is measuring the value of the transitions of care services as a bundle. And that includes not just the pharmacists, but our care managers, our care coordinators, our primary care office that will respond to those post-discharge follow-up. So it is a team effort that is put in place for many institutions to be able to address transitions of care. And when it comes to addressing or evaluating the process, it's really the main data points that we're looking at. It's really the reduction in admissions. We've had several initiatives that are focusing specifically in reducing the heart failure readmissions for our patients who are admitted for heart failure. And seeing those readmission going down, that speaks to the quality of transitions of care in as a whole. When it comes to looking at the pharmacist role in transitions of care, that's where it gets a little trickier. And really some of the measures that we've put in place is, number one, we are utilizing risk stratification as a way to identify patients who could most benefit from pharmacist interventions. Number two, we're measuring how many times is the pharmacist able to reach these patients. Number three, what intervention is the pharmacist focused on? How many medication issues did we recognize or identify? How many of them did we resolve? And these are really some of the ways that we are currently measuring what we are doing. And by any means, this is ideal. These are just where we've started.
And I keep answering every question, but yes, I agree. So readmissions, everyone always wants to look at readmissions and they say pharmacy impacted that. And I think it's first of all, it's a very hard needle to move, and that pharmacy can't really take the credit for that needle moving by themselves. I think that when it comes to transitions of care, it truly is a team effort. Now, what I have done in terms of monitoring our success, and I struggle with this too, and I constantly ask this question as to those webinars or anything that I attend regarding transitions of care. But what I've done is looked at patients who have been readmitted and actually looked to see if there were pharmacy opportunities if the pharmacy didn't touch them. And I wanted to look to see if these would have been preventable if pharmacy had touched those patients. So that's one of the things that actually I've implemented in our process, which has helped us create resources for our system. The second one is looking at the stuff we have caught. We actually collaborate with some of our providers and saying, okay, if this wasn't caught, what might have happened? And that's much more tedious in nature, and it's not so black and white. You can track it, but it is something that we do review on a regular basis, almost like a medication use evaluation, for instance. But those are some of the things that we do. So we look at our interventions, what we've done. We keep a track board of some of our best catches. From the healthcare inpatient side of things, we look at reduced length of stay, which we have been able to get patients out on appropriate therapies, and even some med errors and things of that nature. So those are some of the things that we do look at.
All right, very good. So lots of ways to measure quality with lots of different types of measures. So thanks for sharing all those with us. We do have a question about billing. And if you all have any experience using the transitions of care model CPT codes for billing for transitions of care services.
So I'll answer that one. So we are actually in the process of implementing Pharmacist within the TCM codes and billing. So with those billing codes, they're very interesting. They're very unique, and they're actually great codes that the providers can bill for. So they're typically ran by the primary care provider for that patient. But one aspect to be able to bill it at a higher rate is a follow-up within 48 hours. So we're working now with our primary care providers for pharmacists to follow up with those patients to complete the medication reconciliation. However, we are going to do kind of a MedRec plus. So in order for us to bill, we are going to do that, but we are also going to be reviewing and ensuring that the patient was able to take their medication, that they're not experiencing any side effects. If we see opportunities for enhancements with their regimen. So we are in the process of building that out to be able to have an enhanced TCM, and that's where the role of pharmacy is within that, for that initial touch point within 48 hours after discharge.
And I'm happy to share our model because we work with a lot of the primary care providers in outpatient. We have been very successful when we are managing the Medicare population, because that does provide a pathway to manage these complex patients over time. So for our patients, because with the Medicare patients, those who have 2 or more chronic conditions, we have encouraged to enroll them in chronic care management. So I really liked when Sara said that doing chronic care on an acute care setting. So we keep watching. We get the data for our patients that are hospitalized. We also get this data from the ACOs that our providers are part of. So we have all these access to the portals. So then our care management team tracks these patients. And so we start their care plan of when they're coming out while the patients are still in-house to make sure the medications that they're being put on, patients can afford them and keep the communication with the primary care. And that has been essential because when these patients are enrolled in the CCM, they're the ones who successfully make it to their appointments because someone's already hand-holding the family and the patient ahead of time, communicating with the pharmacy, making sure patients are getting the medications when they get home, and we're able to get a med rec. And so when we do that, then the patients have made it to the day 7 or day 14, depending on complexity. And then the clinic or the ambulatory care pharmacist embedded are able to do that co-visit model in the practice. And then the pharmacists who are in our pharmacies are able to get reimbursed by taking care of the chronic care management code. So I just hope this expands beyond the Medicare population because we see a lot of other patients that could really benefit from that hand-holding when they leave the hospital.
Yeah, thank you. I just had one more comment, and I know that when we're talking about billing codes, we're really talking about on a fee-for-service model. And as we continue to transform into more value-based care, the need for quality transitions of care, it's very clearly known and highlighted just by sharing the billions of dollars that can be saved. So I think we are currently at the point where when we implement great transitions of care and having pharmacists as part of this team, all the plans, all the ACOs are looking at ways to reduce the cost for preventable admissions and readmissions. So if we are able to demonstrate this, that we can do this and we can do this well, I think that in the next few years, the conversation is going to look different because we will be saving billions of dollars to our healthcare system.
All right, lots of questions today. So thank you so much to our attendees. We've got time for a couple more. This next one is about helping to identify patients who are most appropriate for transitional care services by a pharmacist. So does anyone have a specific risk tool or anything you recommend to help identify those patients?
Yeah, so in our institution, what we had implemented 2 different ways that will identify patients who could benefit, who most benefit from pharmacists. Now, it is my personal opinion is that everyone needs to have access to a pharmacist at transitions of care and be able to consult a pharmacist. However, when we talk about sustainability, at the moment we have number 1, we have our own. It's a rush system that identifies patients who are considered high risk. And that is a score that includes not only comes from claims data for medical and pharmacy claims data, but also including social determinants of health data, history of hospitalization and emergency room utilizations. So that is one piece of the score. And the second piece that we include is how many medication changes, were there any medication changes happening at discharge and how many? And I can give you, we put a number 4 medication change in a discharge for Medicare patients required a pharmacist to intervene or a pharmacist consultation for those patients. And the number of the patient that generated was still very high for one pharmacist to be able to handle it. So, and this is how we've been able to grow our services. But we do have some tools that are in place, again, that are focused on claims data, including prescription data and the number of prescriptions that were changed during admissions.
And I know for us, because a lot of systems have their own proprietary risk scores, including ours at our healthcare system. One of the ones that we use that's a little bit more common or available is the Boost 8P. And that takes into consideration medications. So it's actually one of the only risk scores that takes into consideration medications including polypharmacy, as well as what high-risk medications the patient is on, which adds to their final score of their readmission risk. So that's one of the ones that we use that helps us triage which patients we would need to see.
All right, very good. We have time just for one last question. And so I will address this to you and then we will have to wrap up, unfortunately. Thanks again to the attendees for the very active Q&A today. Very much appreciate it. This question we have today, but I've heard this multiple times related to transitions of care, and that relates to discontinued medications and how to appropriately communicate that to the outpatient pharmacy. So we've got a story here. Someone shared with us that said her father's cardiac meds were changed during an admission. He went to get his medications refilled and he was dispensed the medications that actually had been discontinued during his hospitalization. He took the med for a few days before he realized the error. So how can transitions of care pharmacists help to address this care gap?
This is an example. I'm sorry to hear that that has happened to your parent, and unfortunately, this happens more than we care for it to happen. And I think this is another example that highlights how important the role of community pharmacists is in transitions of care. I think one of the ways that we've continued to discuss in our institution is communicating the transitions of care paperwork to the community pharmacy. There is significant effort in our institution to create a network of community pharmacists where we can send the discharge paperwork to the community pharmacy for them to have access to it, to be able to review and fill the appropriate prescriptions. And that it's still in the discussion. It's still a process that is going to take some time. On a more personal note, on my experience over the last several years is really for the high-risk patients, I reach out independently to the community pharmacists and inform them on medications that have been discontinued, make sure that those are removed from the patient's chart. And unfortunately, right now, that has been the most successful way of how I can ensure that that does not happen. It's not sustainable, so we have to continue to look for other alternatives. But this is where our institution is at this time.
And I also think that as this evolves, there are works in where the electronic prescription method, the same way it's sending a new prescription, it should be able to send a discontinued order. And I think that would help. And it would be real time in how we can get this information in the community. So the more advocacy in this space, the more we're going to close those gaps.
So, and Amina, you took the words right out of my mouth. That's actually one of the things that I was going to highlight as well. So right now, we kind of have to do twofold. So we do send a discontinue notification to the pharmacy through our EHR to the pharmacy. However, upon experience or knowing my experience, sometimes it's for some reason rejected by the pharmacy, which is interesting by this panel because we do have community representation and healthcare representation. So sometimes it is, even though we send it, it kind of doesn't go anywhere. So that's why the aspect what Klodiana said is us calling the pharmacy to ensure those prescriptions have been canceled is really at the moment, unfortunately, the most ultimate and easiest way to do this. Now, on top of that, just educating the patient to say, please ensure you do not take this medication anymore, highlight it, go over it, follow up with the patient, ensure they're not taking it. But unfortunately, in the world of auto refill and things of that nature, and us just picking up prescriptions in bulk when we go to the pharmacy, it still tends to happen. So the only way you can really do is to call the pharmacy and get it canceled.
So as Klodiana said, not necessarily sustainable and definitely a place to keep thinking about improving. But thank you to all three of you for sharing your experience on that, and to all three of you for speaking with our audience today. We really enjoyed having you with us and for the fantastic discussion that followed. So do keep in touch. We look forward to continuing to look at transitions of care and other medication quality issues here at PQA. So thanks so much. We will wrap up here quickly with just an announcement for our next Quality Forum webinar. So that will be held on Thursday, September the 15th. And I'm going to go ahead and put the registration link in chat here. So please, if you're interested in attending, go ahead and click the link. You can get registered right away. And we are going to be focused next month on non-traditional careers in pharmacy and healthcare as well, especially as they relate to quality. So please do register for that. We look forward to seeing you then. And with that, we will wrap up. Thanks so much to everyone for joining us, and I hope you all have a wonderful day.
Thank you.
Thank you.
Thank you.